We move now to the state of North Carolina, and the second finalist from that state, as a native I take notice of those things, community care, and we have Alan Dobson and Marion Earls. Thank you both.
Thank you. Good afternoon, and we're happy to be here to describe to you North Carolina's version of Medicaid management and healthcare reform. Managed care was originally envisioned as a system to improve patient care, but over the years it has become more of a system to reduce care cost, often by limiting care. Community Care North Carolina returns to the original premise that the better care results in better health and ultimately saves money. Community care delivers managed care to our Medicaid population through three critical elements. First, primary care physicians provide a true medical home to patients where the patient is known, care is coordinated, quality is first priority. Second, the medical home serves as the hub to reconnect the patient to the broader local healthcare system. Physicians, hospitals, health departments, social service agencies, and pharmacists, an organization of providers working together to improve care. The third, community-based case managers or care coordinators provide the glue that binds all these services together. The local case managers track patients, coordinate their care, offer counseling, and help physicians and patients adhere to the regimen prescribed by their doctors. Unlike almost any system anywhere, patients don't fall through the cracks. The results demonstrated improvements in health, quality, cost savings, and phenomenal growth. Community care's physicians decide on and follow quality standards of specific diseases and are monitored through chart audits. Improvements in asthma care have resulted in a 35% decrease in hospitalizations. Diabetic patients had a 15% improvement in key care indicators, and other outstanding results are in our report. Cost savings have been independently documented at more than $100 million per year to the Medicaid program. Community care began as small pilots, but now consists of 14 regional community networks covering all of North Carolina's 100 counties. 3,500 primary care physicians provide care for 750,000 Medicaid recipients. By these three measures, quality of care, cost savings, and rapid growth, community care has demonstrated extraordinary success. Community care now is the centerpiece of healthcare strategy in North Carolina. It is expanding into the S-CHIP population, mental health populations. We're also seeking a federal waiver to serve our Medicare population and apply the savings to the uninsured. Governor Easley's new health quality initiative will use community care, our local networks, as a platform to bring quality standards to all patients in North Carolina. Insurers covering more than 90% of our insured population in North Carolina have agreed to participate. Let me say again, the community care model has been so successful in improving quality and saving money that all the state's major insurers want to participate. Community care's infrastructure works both in urban and in rural settings. With its community-based infrastructure in place, community care is helping North Carolina address important health issues like health disparities, uninsured, dental access, and child development. We believe community care can and will serve as a national model for healthcare reform. Over 15 states have investigated developing pilots in their state. Many states are now seeking ways to cover the uninsured, but changes in the insurance model alone do nothing to improve quality or reduce costs. Community care does both. We believe that its principles and structure are the future of healthcare in America. Dr. Marion Earls, a clinical director and champion of one of our early networks, will describe how it really works.
My network, P4HM, or Partnership for Health Management, is one of the original 9 pilot sites. Initially a single county network, it is now 3 counties, 32 practices, and 131 primary care providers. At the individual network level, our Medical Management Committee, or MMC, is where the action is. The MMC, which consists of the practice medical directors, public health and mental health representatives, and our care managers, discusses QI initiatives and how to implement them, establishes linkages with community partners such as public health nurses, early intervention, and mental health, and reviews data from our web-based care manager system and reports performance feedback to the practices. Our model is to pilot, refine, and replicate. Because initiatives are developed and piloted by primary providers, buy-in by other providers is facilitated. Examples of successful pilots include the Assuring Better Child Health and Development Project, or ABCD, mental health integration in primary care, and dental varnishing for 0 to 3-year-olds. All are now statewide or going statewide. Data from our ABCD project led to a change in public health and EPSDT policy in our state. And we've also been asked by the Commonwealth Fund and the National Academy for State Health Policy to offer technical assistance to 5 other states. We have just completed assistance to Medicaid primary physician teams in those states, and they are replicating our developmental screening model, where we've been asked now to also offer similar assistance to 20 other states this July.
All right. Can I ask you how this works? I think we understand this from the point of view of the provider community and the networks. From the point of view of the Medicaid person, family, how does this change their lives?
When it gives them a medical home, probably.
Yeah, I'm sorry, it was hard to
It gives them
understand.
the medical home.
In what sense?
A primary care physician where they receive most of their care. But I think that the real innovation is in the community creating not-for-profits that hire case managers to work with those practices and help coordinate care for the patients that are there. So it's basically identifying the people who need care and having a care manager locally who relates not only to the patient's physician, but also the other healthcare providers in the community.
So someone living in rural North Carolina does what? I mean, we just heard about the Arkansas program a little while ago, for example. How is this different? That was, we relied on telemedicine, obviously.
Right. Well, you'd let each network define its resources. So in rural North Carolina, the healthcare system may be a primary care physician, the pharmacist, and a local social service agency, with some of your other resources farther away. So having that case manager locally becomes an extremely important measure to make sure patients get care.
And so you as the patient go see that person, and that's the person you check in with on a...
Right. And connecting the doctor to the pharmacist, to the local small rural hospital, to the other social agencies in these rural communities is the key to the outcomes we receive.
Right. David?
As I understand it, some of the better HMOs around the country do virtually everything you do except the community-based case managers. Is that correct?
That's correct.
Okay. And some states are, well, a lot of states are using HMOs for their Medicaid population, and Virginia, for example, has decided to go that way. So some states that have a lot of rural areas are going that direction. What's your argument that your model is going to produce better outcomes, better quality for the dollar than that model?
Well, I think one is that we've engaged our physicians successfully. If you're a physician dealing with multiple insurers, what we're trying to do is get the practice of medicine to change at the practice level. When we do an initiative in a practice for asthma, the physicians change their practice pattern for all patients, not just Medicaid. We're using state government to improve care. The second part is that we manage our Medicaid program in North Carolina for 6% overhead. And, being a rural state, we had some early managed care in our urban areas, but ultimately this program was about $10 per member per month less expensive on a head-to-head comparison when, as a department, we looked at what was the right way to go. So we moved this out statewide, and actually the legislature has mandated that community care now manage our age, blind, and disabled and other populations.
Let me ask you this question. You're still negotiating with Medicare, is that correct? You're looking for a waiver on Medicare.
We submitted an application for the 646 Medicaid care demonstration, which has been moving through the process over the last 6 months. So we expect to roll up our sleeves with them in the next few weeks if they give us the thumbs up. This committee could potentially decide, well, why don't we wait and see if they get the waiver and see how it works out. Well, a few years ago, we had a program called Smart Start. Hope you won't do that.
Well, but a few years ago, we had a program called Smart Start that appeared here, and the argument was made by Governor Hunt that if you award it to us now, it'll help us a great deal in the state to gain more support, and we decided to do that. Now, would this make a difference in your waiver process?
Well, I think so. I mean, we have been to testify for staffers for the Senate Finance Committee. There's a lot of interest in Medicare about medical homes as a way. We approached this waiver related to the duly eligible population, which is so difficult to manage from a regulatory standpoint because there's two separate programs. And we said, let us take the nursing home population and manage them clinically rather than in a finance mechanism and see if we can improve care and save money. The actuarial study that we did based on what we thought we could save for Medicare in this 646 demo was over $1 billion over 5 years just on the Medicare side. So it's a pretty significant pilot, I think, for the federal government.
David Osborne, last question.
You've got some great data on cost reductions, but in your application, there's a little data on quality having to do with asthma and diabetes. Do you have any other data about quality improvement?
A lot of the data now on quality improvement is actually done as part of report cards to networks. We have recently re-engaged Shep Center at UNC to re-up all our data on our major healthcare initiatives to make sure they're holding. I will tell you that it's very interesting as you get out into the communities, you basically improve quality and then it'll plateau after you get to a certain point. And that's part of our point of the Governor's Quality Initiative is to go into practices. We're going to use our AHEC system, which is our area health education, which is very robust, to hire practice improvement specialists to go into the communities to work with the practices to take them up to that next level of excellence in quality. So we will have some reports later in addition to the cost data, which our legislature requires us to re-up every biennium. That report's due out any day, and it looks pretty good, at least the unreleased version.